Now, there are several controversies and problems about these breakpoint changes, and I want to highlight a few of those. And the first one I'm going to highlight is the cefazolin breakpoint change. And to do this, I'm showing you a normal MIC distribution of E. coli isolates. So these are E. coli isolates that have been tested against cefazolin, and these are the different MICs. And you see the mode MIC occurs at 1. And with the old breakpoint of less than or equal to 4 being susceptible, most of the wild type population would test susceptible. And that's what you would want. But the new breakpoint occurs here. And that is dividing this normal population. The reason it occurs there is because the cefazolin breakpoint is set at a systemic level. So that means it's set at a level you'd be able to achieve in serum. Cefazolin is rarely used to treat E. coli infections that are bloodstream infections. Cefazolin is almost used exclusively for urinary tract infections. And that's okay, because in the urinary tract, cefazolin concentrates, so you have very high concentrations. And even isolates that test intermediate or resistant could be treated with cefazolin in a urinary tract infection because of this increased concentration of the drug. So why do we have a breakpoint that is a systemic breakpoint? I'll talk about that in a minute. But first, let me illustrate that this is a problem that is not only occurs for E. coli, but also occurs for Klebsiella pneumoniae. So once again, this is the old breakpoint, and that's the new breakpoint. So you're going to have a lot of these Enterobacteriaceae testing non-susceptible. This was a big concern. The new breakpoint reflects serum concentrations, and it's at the most common dose, 1 gram every 8 hours. And as I mentioned, the problem is that this overestimates resistance for treatment of a UTI, where drug concentrations can be 20 times what you could achieve in serum. So why don't we have urinary tract specific breakpoints? For a drug like cefazolin, it makes a lot of sense. The problem is that it's difficult to establish accurate breakpoints in the urine and very difficult to implement. And for this reason, the intermediate category has been identified as those isolates that could be successfully treated at alternative body sites, such as a urinary tract infection. The solution to this problem is that CLSI is considering revising the cefazolin breakpoints yet again. And these would be changes that you would see in the January 2011 version of M100. And it would be a change in the breakpoint, the susceptible breakpoint, from less than or equal to 2, or less than or equal to 1, to now less than or equal to 2. And the reason this breakpoint change could happen is because this breakpoint is set for a different dosage of the drug. So this is now set for a dosage of 1 to 1.5 grams every 6 hours. Again, this is a systemic breakpoint. Let's see how that affects these normal populations. So this is where the revised breakpoint would occur, and here you'd have much more isolates testing as susceptible. So once again, though, we'd expect isolates that test in the intermediate range to be treatable if the drug is being used to treat a urinary tract infection. But the idea of changing this breakpoint was useful for 2 reasons. One is having more isolates test susceptible, and also with the breakpoint at this range, we were able to set disc diffusion correlate breakpoints. So at the other breakpoint, the results did not correlate with disc diffusion results, but here they did. So now you'll have both a disc diffusion test and an MIC breakpoint for cefazolin. And once again, this is a change that you would expect to see in the January 2011 document. So there are other controversies. And one of these is reporting ESBL producing isolates as susceptible to cefepime. So if you recall earlier, I told you that ESBL producing isolates will always test resistant to one of the extended spectrum cephalosporins, but not necessarily all of them. Well, with these breakpoints, you'll see a lot of ESBL producing isolates testing susceptible to cefepime. And this is a big concern because we've all been taught to call ESBL producing isolates as resistant to cefepime. So I'll show you some of the data and we'll talk about how some people are responding to this. So the cefepime breakpoints were reevaluated but not changed. Of all of the extended spectrum cephalosporins, ESBL producing isolates will test susceptible to cefepime most often. So why is this the case? Why did the breakpoints stay the same? Well, this is an example of that Monte Carlo simulation. And the breakpoints were set at 2 grams Q12. So if you look at the curve for 2 grams Q12, you see that you would achieve optimal target attainment for at an MIC of 8 or greater. So the susceptible breakpoint was set at less than or equal to 8. Now, if you look at clinical outcome data, this is an example of clinical outcome data for cefepime. So in this case, cefepime was used to treat an Enterobacteriaceae bloodstream infection. And this is the 28-day mortality rates at different MICs. So when I look at this data, I see that there are similar mortality rates for MICs of less than or equal to 1, 2, or 4, but at 8 there's a big increase. And that increase is consistent with the percent mortality that you would see at an MIC of greater than or equal to 16. And being a conservative person, I would want to set that breakpoint between 4 and 8. The problem with these data are that half of the patients who had the isolate with an MIC of 8 were treated with dosages of cefepime that were lower than the dose at which the breakpoint was set. So it's unclear whether those outcome data apply to these new breakpoints. But in general, this has caused a lot of people concern. And there have a couple of different ways of responding. So I think to resolve this issue, more clinical outcomes data would be very helpful. In lieu of that, people have chosen different routes of implementing these breakpoints. So one, there are laboratories that are implementing the CLSI guidelines or these new cephalosporin breakpoints. I think if you do this, it's extra important to convey to both your ID physicians and your pharmacist the dosage at which the cefepime breakpoints are set. Others have chosen to continue to use the ESBL confirmatory test and to specifically use this to change cefepime to resistant. And still others have chosen to use the UCAS breakpoints. And these breakpoints create a very large intermediate range. So here the intermediate range is 2 and 4. UCAST is the European Breakpoint Setting Committee, and now in the world it's almost come down to 2 breakpoint setting committees. There's CLSI and UCAST. So UCAST has this very large intermediate range specifically because there's so little clinical outcome data for isolates in this range that they wanted to keep it very large. And the reason why that wasn't done here in the United States is because there's this perception that intermediate means resistant, that if an isolate tests as intermediate, a drug will not be considered and will not be used. So those are the breakpoint change data that I wanted to show you. And the next thing I want to talk about is how these changes might affect infection control decisions.